Okay, let's see how well you did. We'll go through each of these point by point. And I'll give you a little hint right now to tell you that in some cases the answer is not definitively true or false. And that's partly because of some evolving changes in the DSM-V. And this is the perfect example. The very first question would be answered differently on May 21st as it would be on May 22nd, according to the American Psychiatric Association. This represents one of the significant changes in the new diagnostic manual, and it's something we actually referenced, I believe, way back in Module 1, where we said that depression cannot be caused by an expected emotional response to a culturally accepted event, and that included grieving after somebody has passed away in our lives. But this will be changed in the new manual, where it will allow the clinician, the psychiatrist, to use their own discretion in recognizing that potentially a person's response to grief is more than is socially typical, even though the normal threshold of at least 2 months has not yet passed. So right now, the manual says that at least 2 months must pass before the clinician can call the response depression, but now the clinician can do that anytime they wish to. Typically, however, we should continue to believe the understanding that depression is typically a response, a psychological response that is either out of sync with the apparent trigger or doesn't have an apparent trigger. So we have to understand that when people refer to depression as an individual who's just sad or overwhelmed by life stress, they are not understanding what depression really means. Depression represents truly a mental health issue, and it's going on at a physiological and chemical level in the person's brain. So it reflects that the individual either does not have any apparent reason to be in such a low state, or that their response is beyond what we might expect in given the current trigger. The second question is smoking considered a mental illness? Well, again, this one's a bit difficult to answer because if one goes out and smokes a cigarette, it does not automatically constitute a mental illness. In the old days, in the current DSM, it refers to many drugs as consumed being a mental illness. So the use of a substance could be in itself considered a mental illness. But in the coming version of the DSM, they have integrated the use of the substance and the addiction to the substance and potentially things like withdrawal from a substance into one disorder. So the answer would be if a person was addicted to cigarettes, that would fall into the DSM-V's category of addiction. But if a person is simply smoking a cigarette from a casual perspective, if they aren't addicted to it or dependent upon it, they would not have a mental illness. Is deriving sexual pleasure from kinky behavior a mental illness? Well, again, this one's tricky because while it is in the DSM-V under the category of paraphilias, and paraphilias are disorders relating to sexual behavior and perceptions, it would not necessarily be considered a mental illness unless it caused a person harm or caused harm to others, and this could include the risk of incarceration. Typically, if a person is doing something in a controlled environment, we would not consider it to be a diagnosis of concern, but it still would fit into our category of a paraphilia. It just wouldn't require any intervention. So for example, if two people are consenting partners and decide to engage in behavior that involves fetishizing objects, in other words, becoming sexually aroused by things that are not inherently sexual, like shoes or cigarettes or guns or balloons, which are just a few common ones, then the individual, if they're with somebody who consents to that same behavior, that same activity, is not considered to have a serious paraphilia. However, if they go out and they engage in something like voyeuristic behavior, looking through people's windows, or frauderism, which means rubbing up against strangers for sexual pleasure, those would of course be considered paraphilias of significant concern. And of course pedophilia fits in this category, and we'll speak a little bit more about it later on. Are all mental illnesses treatable with medications? Well, this one is an easy one to answer. The answer is that is false. Many mental illnesses or diagnoses are not considered to be treatable by medication at this time, and that includes, for example, whole categories of disorders such as personality disorders. Although many people do not have a single diagnosis, they often have multiple diagnoses, and so they may be receiving medications for one of them that have an impact on their entire spectrum or syndrome of behavior. All mental illnesses represent a chemical imbalance in the brain. Well, this is an interesting one because the DSM-V is back to or uses the same approach to diagnose people that has always been used, which is to basically assess based on the symptoms of an individual, both observed and reported. And it had been hoped by the American Psychiatric Association way back when it was created in the late 1960s that it would be able to, at some point, assess people for mental illness based on some sort of chemical analysis of the blood or some other similar type of definitive test. And we're still not able to do that, although we are closer and closer to being able to do things like look at brain imagery and understand where things are happening. So we can probably guess that a chemical imbalance or a change in the way that the brain is functioning affects almost every mental illness, but at the same time we cannot say that uniformly and definitively. So for example, with disorders like autism or personality disorders, we really aren't quite sure exactly what's going on inside of the brain. Mental illnesses can be manifested as physical illnesses. Well, this is an easy one to answer. The answer is true, and we'll talk more about these later on, but these are called somewhat somatoform disorders, where a person's mental health symptoms are not manifested in the brain or mind at all, but instead in the physiological responses of their body. It could be pain, could be symptoms of an illness, and we'll talk more about that, as I said, in a while. Bipolar disorder means experiencing mood swings is a true statement, but it more importantly involves mood cycles, and we'll talk about the difference between mood cycles and mood swings later in the module. Schizophrenics have two or more personalities. That is an old idea, very old, popularized by the media, and it is categorically false. It refers back to something that the Greeks thought, and that's why schizophrenia is called schizophrenia, because it is the Greek for split brain. And in fact, we know that this is absolutely not true. And we also know that it is very common for people to use the word schizophrenic, today still to describe the idea of split personality. And we should not be doing that. Psychotic patients are by definition dangerous and aggressive. We'll study this further and learn just why this is false. Many people who are psychotic are actually more passive. They have bladder affect and less volition. They do less in terms of their behavior, not more. So it is a, again, broad assumption that is widely flawed. Some people harm themselves for attention and social support, while others truly wish to end their lives. And this is true. There are some people who will engage in behavior that is self-harming because it has a physiological effect on their body. Some will want to actually truly cause themselves to die. Others will do things like surgery to remove a part of their body that they don't believe belongs to them. And others will do it as a way of garnering attention. And the same is true of suicidal behavior. Some people will engage in behavior that is threatening of suicide or even attempting suicide in order to actually have others respond to them, while others will go actively in search of ending their lives, and in so doing they believe they will find relief for tremendous pain or sadness that they may be experiencing. And we should also add there are some people who would engage in behavior that might appear to be suicidal, which may actually have other origins. For example, there are people who will self-asphyxiate as a part of sexualized behavior. And so that could look like they were dying as a result of, if we came across that person's remains, we might believe they had tried to kill themselves, when in fact they might have been engaged in autoerotic behavior. We want to also take a look at this term we've been using throughout the course. Is mental illness the right term? And the APA has actually spent some time talking about this. The idea that this person's mental illness, or illness I should say, is mental suggests that it affects their thoughts. When we talk about mental processes, most of us think about thinking or remembering or integrating our thoughts and our feelings. But many disorders don't actually affect thoughts at all. For example, there are some that go directly from the brain into behaviors. For example, tic disorders like Tourette's, or sleep disrupting disorders that keep people awake or cause them to sleep too much. Eating disorders that cause people to eat too much or eat too little, or to throw up or cause them to go to the bathroom. And many, many behaviors that are compulsive behaviors that can be described as happening without the person really having a thought about it. Many of the mental illnesses we'll describe affect people's moods or general mood states. They may also affect their anxiety or cause them to have unusual degrees of fear. Some affect people's sexuality, and particularly what the individual finds arousing. Some will actually be at the very root of how a person identifies. So in some cases, people may believe that there is a disjunction between who they are physically and who they are sexually or gender-wise. So they may believe that they're a man in a woman's body or vice versa. Or they may have a particular different view of themselves from a personality approach. And we talk about, in the old days, we talked about multiple personalities, but now there's something called dissociative identity or dissociative identity disorder. And people may actually have more than one personality, but they aren't necessarily aware of their other personalities. And that, by the way, is something that is popularized in movies, but is actually quite rare. And then there's the person who has what we call body dysmorphia, who actually doesn't believe that a part of their body belongs to them. And this can be very unusual, where a person will feel as though the hand that they have belongs to somebody else and will actually very much want to remove it. Addiction, of course, is another form of mental illness, and again, it can affect the way people think, but it also can occur at a physiological level. We've discussed in Module 7 and elsewhere, where it's really getting at the root of people's drives. Our physiology can be affected, as we said. We talked a little bit about that in the last slide, about the fact that disorders can manifest as physical illnesses or as pain. So what the APA prefers, and of course the APA is the American Psychiatric Association, so it shouldn't be a huge surprise to us that they prefer the term psychiatric disorder, because it more aptly encompasses all of these types of disorders. What I think we need to be focusing on is not so much the disorder as much as talking about promoting mental health or wellness. And the term mental health, again, suggests thoughts, but I think we use our thoughts to evaluate our wellness and to evaluate our quality of life. And so we can probably accurately describe an individual as having mental health if they are able to live a life free of concern about any of these psychiatric symptoms. The definition of a mental disorder does not appear to be changing in the new DSM-V, although if it does, we will try to put an update for you on the website. But in my research, it appears to be very similar to what it was before, even though there were some proposed changes. So a mental disorder is defined as a clinically important collection of symptoms, and these can be behavioral or psychological, that causes an individual distress, disability, death, or the loss of freedom. And that, as I said, is from the current version of the DSM-IV. Now, these symptoms can be transient. They don't necessarily come on at birth or last all life long. They can come at any time in a person's life, and they can leave at any time in a person's life. Or, in more accurate terms, many of them often fluctuate or go into remission and return. We said this earlier about depression, and it's true of disorders in general. They cannot be a common expected reaction to an event, such as typical fear, worry, guilt, or grief. So when a person is responding to something, we need to actually take a look at what's happened in their life, and we need to consider their cultural background. So for example, if an individual grieves for an extended period of time, but they come from a culture where that's expected, then we cannot apply the same overlay of criteria that we might hear in the North American culture, where we typically don't have a ritualized expectation around the length of a grieving period. So as we move from the DSM-IV to the DSM-V, some fairly significant global changes that we want to talk about, and then later we'll talk about some of the specific category by category changes. So the revision process for the DSM-IV began way back in 1999 and really kind of kicked in earnest in 2007. There was a version of the DSM-IV that was revised just in terms of its text, in terms of its clarity of writing, and this was called the DSM-IV TR, text revision, before we went to the DSM-V. And so we can expect that the DSM-V is likely to last in the neighborhood of 15 to 20 years as well, but that would be predicated on evolving research. The APA has approximately 36,000 members, and these people played an active role both in forming subcommittees that examined each category of the book as well as the book as a whole, and in giving feedback on the actual proposals by these subcommittees. And this work was not only reviewed by members of the APA, but also people from around the world, including folks who work in the psychosocial realm, like psychologists and addiction experts, who are not psychiatrists. The number of diagnoses in the new manual is not very different from the old one according to the APA, and they suggest that this is somewhat different from other medical disciplines which tend to have expanded the number of diagnoses as they move forward. What has happened in the new DSM-V is that things are recategorized or associated differently than they used to be, and this is predicated on not only clinical experience of their members, but more importantly and more impressively, based on neurological research. They have ended the multi-axial system of diagnosis or classification, and we'll have to go back all the way to Module 1 here to think about this briefly, because the multi-axial classification system, and we talked about it also in Module 3, is used to, or was used to, assess not only a person's primary mental disorders, but also the underlying conditions such as intellectual disability or personality disorders that could affect the diagnosis of an underlying condition. And also looked at medical conditions, looked at the person's psychosocial factors such as their job, their marriage, that sort of thing, their housing, and finally had a scale, the fifth scale, for assessing a person on a continuum of looking at whether they were improving or not. At the end of the day, the multi-axial classification system is being abandoned based on the fact that many clinicians simply did not use it or did not truly understand how to apply it. But what has happened is that this system is being replaced by a psychosocial notation approach. And I don't have more detail on this, but it's one of the things that I'll be most earnestly interested in seeing when the new manual arrives. It is important, of course, that clinicians continue to look at the psychosocial factors involved in a consumer's or patient's life instead of just looking at the mental disorder. And I hope that the new DSM-V and that anybody who's employing it is going to be moving further along the realm of towards a biopsychosocial approach instead of strictly looking at a biological approach. What's also happened is that in the old manual, the ability existed for clinicians to say that if something didn't fit into a set of criteria, they could still make a diagnosis, and they called this an NOS diagnosis, or not otherwise specified. So what they might say, for example, if a person was somewhat autistic seeming, but didn't fit the strict criteria for autism or one of the other disorders, they went to the last category in each chapter, and they called it, in this particular case, autistic disorder not otherwise specified, or sorry, pervasive developmental disorder was what they would have called it in the old one. And what they've done here now is they've said, if you want to describe a disorder as being in a particular category, you can't just simply say not otherwise specified. You have to identify specific traits that you believe make that individual fit best in that category. So that if that person was to go to a different clinician, they would have real clarity in their diagnosis and they would understand what specific traits were being addressed. And this is, I think, an important step, because what it suggests is that the traits are more important than the overall diagnosis. And I can't agree more with that particular idea. We also are seeing, in many cases, a move to a spectrum approach, particularly in the areas of autism and schizophrenia. In the old approach, these two disorders were lumped into categories, and so to some extent was what was called mental retardation, and we're going to move away from mental retardation to using the more popular and socially valid term of intellectual disability. And instead of saying people get into category 1 or 2 or 3, what's going to happen is they're going to say that individuals have the disorder according to a spectrum, and they will note the particular symptoms of the individual and the particular severity of the individual at the time of diagnosis and as treatment ensues. And this is probably, again, a more descriptive and meaningful approach than simply giving a person a particular label. It should be mentioned that in the case of the autism approach, not only will there be a move to a spectrum approach, but the term autistic spectrum disorder, which has been widely used in the community, will now be the actual diagnostic term. And it should also be noted that there's some considerable controversy around this, because many children in particular are funded according to this diagnosis. The Ministry, for example, of Education in British Columbia has a specific funding structure based on whether a person has an autism diagnosis or a moderate intellectual disability diagnosis and so forth. And that's true across most westernized localities, state to state, country to country. And so many people are concerned that this will change things like whether or not insurers will pay for programs or services, or whether state or provincial governing bodies will pay for educational adaptations and services and so forth. And the dust is yet to settle on some of these changes. There will be undoubtedly much controversy in the next few years and much adjustment in the next few years as systems try to accommodate this new revised approach. And so if you're working in any first response capacity that is professional, whether you're an educator, a police officer, a doctor, a nurse, somebody working in a psychosocial community organization such as group homes, you are undoubtedly going to see some downstream sort of trickle effect to these changes, and you'll need to be ready to adapt. The DSM-V will be divided into 3 sections, and the first section will describe the changes that are in the manual and how to use the new manual now that the multi-axial classification system is gone. Number 2 will be the thickest section most likely, and will describe the disorders, many of which remain either unchanged or have moderate wording differences from before. But the third section is interesting because what has happened is that the APA has elected to include a number of new disorders tentatively, saying that these require further research. And so they have said, yes, they can be diagnosed, but we recognize that more information is needed. There were a number of disorders that were not included that were proposed, such as hypersexual disorder, which some people refer to as sexual addiction. That did not make the cut. Another one was parental alienation disorder, people becoming so detached from their parents that it causes major dysfunction in their lives. And that one didn't make the cut as well. Those are just 2 of the ones that didn't get into the book, and there are others we'll discuss in a moment that did. So we're going to pause for a moment and do a journal entry. In 2 minutes, we'd like you to list as many mental illnesses as you can think of. After you've listed them, take a look at what other people have written and answer this second question. Did you write symptoms or disorders? What's the difference between a collection of symptoms and a disorder? We'll come back and continue on after you've done that.